Okay. Okay, counsel and the defendant are present in the courtroom. Jury's currently out. We just finished an in-camera discussion. Was something you wanted to put on the record?
Yes, Your Honor. At this time, I would request that the court consider allowing this expert or any other subsequent experts to possess a laptop computer at the witness stand for purposes of accessing the medical records as discussed. The reason for that is that there is no indexing or pagination in the medical records that sit here, and we could get into some situations where Dr. Schweiger or other experts that may appear before this court would be able to save time by using the search feature on a laptop to address questions.
Is it a clean laptop? It's not your trial laptop, is what I'm asking.
Yes, but we would open it to just the medical records portion. It doesn't have other things on it, but I would trust that the witness would not go swimming in the laptop.
That was just an anticipatory question.
Yeah.
Ms. Menashe.
So it's a laptop that belongs to the state of Ohio?
Well, that's not the issue. Is it the one they're using for trial? And is there other documents on there or not? Or is it a clean one with just the medical records?
Well, there was going to be a series of questions because I know how the court feels about foundation. But first, it's a state of Ohio laptop?
Yes, it is.
That has your whole trial file on it?
It has a trial file. He wouldn't know how to get into that, but yes. But if the court would permit that to happen, those medical records to be available, we could load them all onto a clean laptop, have it over here this afternoon, and use it for all the experts coming up. And put nothing but the medical records on the laptop. I'm sure we could achieve that.
And, Your Honor, just logistically, how does that work? It's like, would it refresh your recollection, and then he reviews something that I don't know that what he's reviewing? I don't know if it actually is refreshing, because it might be a different document.
Right.
And how do we get a witness to search through direct examination that is supposed to be non-leading?
Well, it would be transitional for most of that, but, I understand your point, but it's the same questions going across. My problem is it's not been specifically set up for this sole purpose. And we can always hook it in to the system, I think.
I'm just trying to save time, Your Honor, because, one of us can clearly go to, search a word, come up with pain scores or whatever the issue is, and then, publish it. But it would just be, I think, a lot faster if the expert themselves, who are used to electronic medical records, could do that for us. I see it as a time saver. That's all. I'm not trying to...
Well, for right now, let's go with what we got. I won't consider it until I know it's a clean machine.
Yes.
With nothing else on it, and it's just the medical charts.
Okay, great. I think we can do that.
And then we can deal with the issue at that time.
And we'll make it available for defense experts also.
Okay.
Okay.
Let's bring him, David.
For the record, I object to this. I spent 30 hours this week in pulling records, so it's possible. I know, because I didn't sleep. So I just don't think it's best practice. This is a murder case. I think that we should be able to see exactly which document we're talking about. And I'm not really sure how it saves time. I also don't think it's an appropriate visual for the jurors to now be seeing someone that the state has hired able to manipulate their own laptop. I think that optically that's not appropriate, and we will not, our experts will not be doing that. So those are my concerns, and I object to the practice.
It is out of the ordinary.
I understand, Your Honor.
We'll just do it the long way. Don't even go get to the computer. Sorry.
So, does the court understand there's no pages on these, no dividers?
Okay. You guys bring the exhibits in here.
I'm sorry, Your Honor?
You guys bring the exhibits in here, okay? I'm not responsible for their creation. I just judge them, okay? So, I'm sorry they're not paginated, but, just show them the blurb that you want to show them,
Okay, thank you, Your Honor.
okay?
Ready?
Objection be sustained then. David's getting them. I'm going to swear you back in when the jury's present. Okay, just relax.
Yeah, I know.
And then show them on screen without the jury first. I don't want to do it that way.
I know. I'm old, I'm slow. I'm not taking that.
Yeah, but credit to Taylor.
All rise. So who hurt themselves?
Okay. Someone strained their leg. They may put their foot up there on the cross beam right there.
We pushed them.
Okay, whatever. So he puts his foot up because he has to elevate it. Don't take offense, folks. We're trying to make it work. You all be seated. Doctor, please raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes, sir, I did.
I'm a little ahead of myself. Turn around there. Ms. Grubb, why don't you call your witness?
Thank you, Your Honor. The state of Ohio calls Dr. John Schweiger.
Okay. Now, Doc, go down the seat. Get comfortable. You got a mic there in front of you. Okay. For the record, I need you to state your name and spell it for us, please.
Certainly. My first name is John, John, Walther, Walther, Schweiger, Schweiger, MD.
You guys hearing him okay? Now, a little more volume?
I heard it, just spell it again.
Spell it again.
Yes, obviously John, John, Walter with an H, so Walther, and then my last name Schweiger, Schweiger.
Now, you all hearing him okay? Okay. Let's grow.
Thank you, Your Honor. Dr. Schweiger,
what is your professional address?
My professional address is 1 Tampa General Circle, Suite A, 327, Tampa, Florida, 33606, Department of Anesthesiology and Critical Care Medicine.
Thank you. Please share a little bit about your post-high school education.
Certainly. So after I graduated high school, I attended Wesleyan University in Middletown, Connecticut, where I studied religion and philosophy, getting a Bachelor of Arts degree. During that time, I also took all the pre-medical requirements, and in my senior year, I applied to medical school. I was accepted at Rutgers Medical School in New Jersey, which was my home state, also known as Robert Wood Johnson Medical School. I attended there and graduated with a medical degree, so an MD degree. In my last year, I matched in internal medicine at Cooper Hospital, University of Medical Center in Camden, New Jersey, where I did my internship. I had also matched in anesthesiology at Temple University Hospital, which is located in North Philadelphia. I served from July 1990 through June 1993. The senior year, I was voted chief resident in the Department of Anesthesia, overseeing the educational process for the junior residents. And then I was accepted to a critical care fellowship at Temple from July of 93 through June of 94. That was co-sponsored by the Department of Anesthesiology and Cardiothoracic Surgery. And after I finished the fellowship, then I took my first job assignment.
Thank you. What type of medicine do you practice?
So I'm primarily a hospital-bound physician, meaning that I practice at Tampa General Hospital most of the time, with a little practice at surgery centers and some of the smaller hospitals. I am primarily a critical care physician, also known as an intensivist, meaning that I staff the various ICUs. And then the other part of my practice is as an anesthesiologist, taking care of patients in the operating room and throughout the hospital. And in both of those arenas, I practice pain medicine, which is the delivery of medications to reduce, alleviate, or remove pain from patients.
Thank you. Are you board certified?
Yes, I was board certified, passing all my tests on the first attempt. Initially, I was board certified in anesthesia April of 1994. The following year, I was invited to take the critical care boards, and I passed those on the first attempt. And then that would have been 95. And then in 1996, I passed the the American Academy of Pain Medicine boards in acute and chronic pain management on the first attempt.
Thank you. And do you maintain those board certifications to date?
Yes, I'm still board certified in all three areas of medicine.
Thank you. What percentage of your time do you spend in the actual clinical practice of medicine?
So I would say that I spend about 95% of my work week at the hospital clinically practicing medicine, where I'm seeing patients either in the operating room or in the intensive care unit. And then the other 5% is in administrative, managing the Department of Anesthesia and Critical Care, some professional guidance for medical students, residents, and fellows, and then a very small amount on research.
In the past, have you been an instructor at a medical school?
Yes, in my fellowship year, I was an instructor at Temple in the Department of Anesthesia and Critical Care. And then I was full-time faculty at the University of South Florida College of Medicine, which is located in Tampa, Florida. They recruited me from Temple in '94. And then since I left the full-time employment of the university, I've remained as a clinical professor, having been promoted to full professor in 2016 at the University of South Florida College of Medicine.
What positions of trust or supervision do you currently hold at the hospital or in your medical practice?
Yes, so starting in 1999, I was appointed as the Director of Critical Care Medicine, overseeing both the educational and the delivery of critical care at Tampa General, which is a 1,000-bed hospital that's the major teaching affiliate of the University of South Florida College of Medicine. Then I was elected to be the Vice Chief in the Department of Anesthesia, which was, I believe, from 2019 to 2021. And then in 2021, I was elected Chief of Anesthesia, the department, where we currently have 88 anesthesiologists and about 220 certified registered nurse anesthetists. I'm also been the chair of the Critical Care Competency Committee and the Critical Care Steering Committee. I've served as either chair or vice chair for numerous committees at Tampa General, and then also overseen the resident selection process and resident counseling process.
Thank you. Are you published?
Yes, when I was a full-time employee of the University of South Florida, one of the requirements was to publish in the peer-reviewed medical journals. So I've written numerous book chapters covering both anesthesiology and critical care medicine. Additionally, I've had publications that are peer-reviewed, meaning that there's an editorial board that proofreads them for content, makes sure they're scientifically valid. And then I've had many more publications in non-peer-reviewed scientific articles to educate fellow doctors in both anesthesia, critical care, and surgery.
Do you know approximately how many articles you have penned?
I would say somewhere on the order of 40 to 50 articles.
Have you lectured?
Yes, I've lectured all throughout the United States, not only in my home state of Florida, but in various regional, state-sponsored and national meetings, again, in both the areas of anesthesiology and critical care medicine.
Are you currently doing any teaching?
Yes, even though I left the full-time employment of the University of South Florida in 2004, I've never left my responsibility to teach the medical students there, the residents, and the fellows. So I've continued throughout that whole time as what's known as clinical faculty, meaning the medical school assigns me residents and fellows to train. I give daily lectures in the intensive care unit. That's usually in the noon hour for those various students. And then I'll also periodically be invited to the university, for example, in the Department of Pharmacology, to lecture on anesthetic drugs for the operating room or the ICU. And then I lecture extensively to the nurses, not only at Tampa General, but to the regional nursing societies on various continuing nursing education topics.
Can you illuminate what kind of advances you feel have been made in your area of specialty as an intensivist over the last 10 to 15 years?
So over the last 2 decades, there have been major advances in the science and the medicine of critical care, both in terms of our ability to diagnose patients' life-threatening problems through new blood tests that we have available, new imaging such as CAT scan and MRI, and then also in terms of processing that information more rapidly so doctors can form a more effective differential diagnosis. Also in terms of new medications that have come to the forefront that we're able to employ, if not to arrest disease totally, but certainly to slow the progression of the disease. Also, we've made major advances in our understanding of both analgesia, which is pain relief for critically ill patients, as well as for the management of sedation in the ICU. When I was a medical student and a resident, it was often felt that patients should be in a state of suspended animation in the ICU, and we realized that that's not the best way to get them better or to promote their recovery from the ICU. So we have much more advanced techniques that can really allow patients, for example, to breathe spontaneously on a mechanical ventilator and be able to separate more rapidly from the ventilator. This, of course, has really become topical the last 2 years with the coronavirus and the pandemic with COVID, since we've had major breakthroughs in our understanding about lung function, how the ventilator either can help or hurt the patients, and then also ways to expedite their recovery, such as things like putting them on oxygen machines that can actually circulate their blood, put oxygen in the blood, and take carbon dioxide out, called ECMO, which 20, 30 years ago was really reserved for newborn babies, and now we found that that's quite helpful in selective patients, managing them as adults in the ICU.
Thank you, doctor. May I approach?
You may.
Dr. Schweiger, I'm handing you a document entitled States Exhibit 32A. Could you please tell me what that is?
Yes, so this is my resume, or what's in medicine we call it curriculum vitae, and it basically lists my education, my training, my work experience, the various committees that I've served at Tampa General and the university, and then the publications, chapters, peer review, non-peer review, and then a lengthy list of all my lectures.
Thank you. Would you just flip through it, make sure that I didn't give you a blank bunch of paper?
Yes, this is accurate as of January 1st, 2022.
Thank you, sir. Your Honor, would the court like me to formally offer him as an expert in this case?
Wrong courtroom.
Okay, thank you. I'll proceed.
We're talking about a custom from courtroom to courtroom. Okay? You can proceed.
Thank you, Your Honor. Dr. Schweiger, could you please describe the hospital service that you offer, starting with your ICU practice?
Yeah, so starting with my intensive care unit practice, Tampa General has approximately 1,000 hospital beds. So it's equivalent to major medical centers such as the Wexner Medical School here at the Ohio State University. They would be similarly structured type of institutions. We have approximately 175 ICU beds. We achieve almost 99 to 100% capacity on any given day, meaning that we usually have some patients waiting in the emergency room or in the recovery room or the operating room to come in. We have to try to discharge patients. So we have a essentially full adult ICU. We have basically 9 various ICUs throughout the hospital. Those include the medical ICU, the surgical ICU, the burn intensive care unit, of which I'm the co-director. We have the trauma ICU, the transplant ICU, the vascular ICU. We then have some outlier ICUs in the new building that we've retrofitted, which can have a combination of medical and surgical patients. And then we also have the Neuroscience Institute that's in the Bayshore Pavilion that has another 32 beds. So in terms of my practice, I usually work 7 days straight in the intensive care unit. So for example, I'll start Monday and I'll go through Sunday. The weekend are 2 16-hour shifts, so I'm just coming off the weekend, this past weekend, when we're in the ICU. We have 3 major ICU services at Tampa General, so anesthesia critical care being one of them. So we would see approximately a third of the patients in the adult ICU. Then there's a surgical trauma team that would see a third, and then the medical ICU team would be the third. Again, we routinely don't see patients under the age of 16 except for true emergencies, such as at night if the pediatric people need help with an intubation, putting a breathing tube in, or a line. In terms of the operating room, we have approximately 40 anesthetizing locations. We have 22 operating rooms in the main operating room, 8 on cardiovascular. We have a separate burn ICU. We have 4 operating rooms for gynecology, and then 6 labor and delivery hot places. And then we have a very busy 10-bed gastrointestinal unit where endoscopies are performed. And then there's some other outlying institutions. And again, those are staffed by anesthesiologists and primarily CRNAs.
Do you not only practice but oversee these?
Yes, so as an attending physician, obviously I'm seeing the patient, I'm talking to the family, but one of my responsibilities is also to work in what's known as a care team model. So in the intensive care unit, my primary team has currently 15 advanced practice providers. Those include both physician's assistants and advanced registered nurse practitioners. Then we usually have 2 or 3 residents, and then we have assigned medical students. And we would divvy up the patient list so that each provider would be assigned a certain number of patients, and then the group would see those patients and they would report back to either myself or another attending physician, where we would do multidisciplinary rounds. And those include the attending physician, the resident or medical students, the physician assistant and advanced registered nurse. But we also have things like a dietitian, the pharmacist. It can be also the charge nurse or someone from nursing, so that we can communicate with each other about the patient's status, what the plan is, and how we're moving forward.
Thank you. During the course of your practice at Tampa General, do you have patients who require compassionate or palliative extubation?
Yes, certainly at any ICU that I practice in, there are those patients who, for one reason or another, do not respond to therapeutic interventions, whether that be medical interventions, surgical, or mechanical, such as the breathing tube. So in those patients, we have a palliative care team that we consult with in regard of end of life and what the goals of care are. And then in multidisciplinary discussion, some of those patients will progress to what's known as a terminal extubation, meaning that when we collectively decide to pull the breathing tube out, we will not plan to put it back, even if the patient's condition deteriorates further, because the collective opinion is that the patient is truly progressing towards the end of life.
And is it your testimony at this time that you have engaged in all phases of the decision-making and actually performing the medical services that would be needed to achieve such an extubation?
Yes, as my role not only as an attending in critical care, but also as the director of critical care medicine, I participate in all phases of both the palliative care service, the end-of-life discussions, and, if need be, terminal weans, meaning backing off from the ventilator, up through terminal extubation. In fact, as recently as yesterday, I participated in such a process.
Okay, thank you. Let's turn the page. Do you have a certain percentage of your income that comes from either consulting or being an expert witness in legal matters?
I do. So for the last 2 decades, partly because of my reputation within the medical community and also because of my publication and lectures, I have been asked by various attorneys, both defense and plaintiff, to review civil litigation cases for them. And I have done so over that. And so a percentage of my income, which is approximately 15%, is as a result of my work as a medical legal expert.
Thank you. Describe how this became a part of your life. How did you get involved in it?
So I was first asked to give a statement for an attorney back in the late 90s because I was the treating physician and the attorneys were seeking information about the care of the patient. And then later that year, that attorney called me and said that he liked the way I explained the medicine during my sworn deposition and would I review a case for his firm. I knew very little, if nothing, about forensic work for attorneys, so I turned to my chairman. He set up certain parameters for faculty at the university for participating in medical legal reviews and served in a voluntary role as sort of a mentor to the faculty. And then from there, I began slowly to review cases that were referred by other senior faculty at the university. And then eventually, probably around 2002 to 2003, I was independently contacted by attorneys to review civil litigation, meaning medical malpractice cases.
How often do you review cases cases involving medico-legal issues?
I would estimate on the order of about 20 cases a year for the last 8 to 10 years.
Do you charge for reviewing one of these cases?
Yes, I do. I have a fee schedule that I charge. I charge $500 an hour for review of medical legal cases, and then for sworn deposition testimony, I charge $550 an hour, and then finally for trial testimony, I charge $600 an hour.
Thank you. Do you advertise yourself?
No, I've never advertised throughout my career. There are organizations that will advertise for doctors. I see no need to do that. Again, I'm not there as an advocate. I'm really serving as a medical expert. So I think that to advertise is really not ethically sound as a physician.
Are you on any special interest panels?
I've served on panels within the institution, both at the medical school and at the hospital
Sir,
to formulate
I think
policy.
you misunderstood. Are you on any legal special interest panels?
No,
like
I'm not.
defense
No, I'm
attorneys
sorry.
yeah.
No, I've not served on any panels for defense or plaintiff attorneys. I'm sorry, I misunderstood.
That's okay. What percentage of the time do you review for the physician versus the patient?
So in terms of the cases that are sent to me, so when I open a file to review, 40% are on behalf of either the hospital or the physician, and then 60% are on behalf of the plaintiff, the person that is asking for the review of the care was provided.
Thank you. Have you been asked in the case of the state of Ohio versus William Husel to review medical records?
I have, yes.
And does this include the medical records of all 14 of the alleged victims in this case?
That is a true statement.
Have you prepared reports in this case?
Yes, after independently reviewing each of the medical records, I did set out to draft a written report on my opinions and facts regarding the review.
Thank you. February 20th. Your Honor, if I may approach.
You may.
I'm handing the witness a document entitled States Exhibit 32B. Dr. Schweiger, could you tell me what this is?
So this was my initial report that I wrote. It was dated February 28th of 2020, and that was my report to the prosecutor's office.
Thank you.
Did you also create reports for each of the individual patients in this case?
Yes, approximately a year after preparing the initial report, I was asked to draft individual reports regarding my review of each individual case, and I did do so.
Thank you. If I may approach.
You may.
I'm passing the witness a ring binder which contains States Exhibits 32C through P. Sir, could you please tell us what each of those are?
Yes, so this binder includes copies of the individual reports that I authored related to each of the 14 medical records I was asked to review.
Thank you. And is it a fact that those range in size from about 10 or 12 pages to like almost 30 pages?
Correct.
There are various of various lengths.
That's correct.
Is that correct?
I would say the shortest was about 10 or 11 pages, and the lengthiest one was 28 or 29 pages.
Thank you.
Doctor, can we agree that any opinion that you give in this case, you will express to a reasonable degree of medical certainty unless you indicate otherwise?
Yes, I agree to that statement.
Doctor, what does the term standard of care mean in the medical world?
In the medical world, a standard of care.
Objection, Your Honor.
Let's sidebar this one.
I'm sorry, Your Honor.
We're going sidebar. David? Time for a law school lecture, okay? The word standard of care comes out of medical negligence cases. That's generally where it's in there. It can be used for other things, but when we talk about violation of a standard of care, that's usually in a negligence case, and that's not part of this case. This case is about proving purpose, okay? Now, I don't know where it's going on this, okay? But just because the standard of care is violated, that's insufficient. There has to be other facts or other circumstances to support the purpose. Okay? Any objections on the charge?
No, Your Honor, thank you.
Okay. Ms. Grubb.
Thank you, Your Honor. Let's turn to the typical ICU patient.
Well, why don't you finish up what we just explained? You're going to come to that? Okay.
Well, I'd like to come back to it, Your Honor. It seems that perhaps in a later portion of my examination, it would be more appropriate.
Okay.
Let's talk about when you first undertake treatment with a new ICU patient. What does appropriate care require?
So when first consulted to see a patient to determine whether or not they should come to the ICU or if they're already in the ICU, the first step is to obtain a comprehensive history of the patient. Again, many of the critically ill patients won't be able to talk to me as a physician, so I would be dependent upon what's in the medical record already, either from the emergency room or from the transferring institution or physician. We obviously will get history from families or from significant others, any source that we can get information. Next, besides getting the vital signs, we want to do a comprehensive physical examination in order to uncover what organic dysfunction the patient's body is presenting to. We will then order appropriate laboratory and diagnostic studies, so blood work, EKG, chest x-ray, perhaps other imaging, to try to get an idea and try to identify more scientifically what the problem is on the patient. The next step, and perhaps one of the most important early steps, is to form a comprehensive differential diagnosis. By that, what that means is you take the number of diagnoses that you have for the patient and you put the most important one first, the one that really needs to be addressed because it could threaten the life or well-being of the patient. And then you prioritize them from most important to least important, and you create a therapeutic protocol based on that differential diagnosis. diagnosis, which might change while the patient's in the ICU. It's dynamic, but you want to reevaluate that every day. And then perhaps lastly is good communication, not only within your own team and to the nurses, but to the other services that are involved in the care of the patient, so that the various surgical, medical, nursing teams are all on the same program with the patient's care.
How would you characterize the medical condition of the typical ICU patient?
So the typical ICU patient has either one or more organ failures or dysfunction. So for example, if the patient can't breathe and their lungs are sick, that would be called respiratory failure. So in order for a patient to get in the ICU, they usually either have impending failure dysfunction, meaning you know as a doctor it's coming, you can see the way they're deteriorating, and you want to intervene early, or they're already presenting with two or more problems, like they may have liver failure and kidney failure together, and you're getting the patient in the ICU.
Does documentation and protocol matter in dealing with critically ill individuals?
So documentation is essential to the delivery of appropriate care in the ICU. First, the vast majority of the patients in the ICU either can't speak because they have a breathing tube in their throat and in their airway, or they're sedated with medication that makes it impossible for them to communicate. So it's very important to chronicle in the medical record so that each team knows not only the patient's responses, but also our thoughts. So the medical record, whether it's on paper or electronic, really serves as the fulcrum in which the various healthcare teams communicate with each other. This is especially true in modern medicine when you have more and more subspecialists come into the ICU. So you may have a cardiologist that just focuses on the heart, a diabetic doctor that just focuses on blood sugar. They may not be communicating with each other verbally. They may be communicating with me as the intensivist, but the chart then allows all the doctors to know what's going on and facilitate communication. And then also with each day they're in the unit, because many of these patients are in the ICU weeks or months. You can see with COVID, some are there 4, 5, 6 months. You really need accurate medical documentation. And then equally, you need to follow protocols so that the patient's care can be similar to what other patients with those disease states are undergoing.
Does that allow for the advancement of knowledge?
Correct. Both by documenting appropriately and by having protocols, future generations of doctors, of surgeons, of nurses are going to advance the field. Just in the last 2 years, we've learned a tremendous amount of knowledge about how to manage COVID patients based upon not only good documentation for any one patient, but by pooling that data together, both within hospitals and then across the country to figure out what is the best way to treat patients. So without appropriate documentation and without protocols, really then every doctor is just going by what their impression is, and you're not getting a unified approach.
Thank you. In your practice, and as you work with us or others, is it important for physicians to be accurate in their record keeping?
Yes, well, going back to the last question, one of the goals, obviously, for a critical care doctor is compassionate care of the patient. But we're also there to advance the greater body of knowledge within critical care, within surgery, within anesthesia, so that each generation can advance the delivery of healthcare system. So again, it goes back to by appropriately documenting, by appropriately following protocols, you not only figure out what works, but you also figure out what doesn't work so you don't repeat the same mistakes moving forward. So it also is important because obviously an ICU is 24 hours, 7 days a week. And so you have various shifts of nurses and residents going through there. No one, no matter how dedicated they are, can be there day in, day out, day in, day out. So if you don't have that appropriate communication in the medical record as well as verbally, things are going to get missed within the ICU.
Is there anything appropriately concluded from inadequate medical records?
So often, inadequate medical records speak to a lack of attentiveness of the treating team for the patient, that, again, they're not really focused in on the comprehensive view of the patient. Because, again, if you're spending the time doing the history, doing the physical, looking at the labs, you're going to want to document that and also document your thoughts on what is that differential diagnosis. Now, again, even in a busy ICU, and we have 175 ICU beds, and I may have many, many patients to care for, I still take the time to document, my team documents, so that the people coming behind us know where we're at that given moment and what the trajectory is of the patient's care and also of their prognosis.
Let's turn to the patient and the family. How do you prioritize treatment of the patient while demonstrating care for the family?
So that's a very important aspect of the appropriate delivery of health care in an intensive care unit. As I said, the minute that a patient comes to an ICU, families realize that that patient has usually one or more impending or actual organ failure. So the families themselves have tremendous emotional investment in those patients. These are usually, a patient's mother or father, their spouse, their offspring. They're emotionally tied. Also, as I mentioned earlier, that many times the patients can't verbalize. They may have had a stroke. They may have to have the breathing tube. They could be in shock. So we're eliciting history often from the family. So early on in the ICU, the family is involved. So although our primary focus is always addressed towards excellent patient care and meeting the needs of the patient, we also have to be empathetic to the concerns of the family and make sure that we're including them not only in the daily communication, but also in decision-making, especially if the patient isn't able to participate in the right of self-determination. I mean, if the patient can't say, Dr. Schweiger, I want treatment A or B, then we should try to seek their closest kin, whether that's a healthcare surrogate or a family member, to guide us and to tell us what that patient would want.
Talk to us about the duty of the physician to the patient as opposed to the family's wishes.
So ultimately, we take a sacred oath as a physician when we graduate medical school, and that's doctor, do no harm. Again, we can't always guarantee to a patient that we can cure their disease. We certainly can do our best to try to reduce their suffering, to try to reduce their anxiety. And so we always try to put the patient and the patient's wishes first. As I mentioned earlier, you want to incorporate what the family has to say, because many times the patient has had conversations with the family explaining what they would want if they were ever faced with life support situations or critical illness. So we will always incorporate their decision, but ultimately we must do what's right for the patient.
Thank you. What markers do you look for to determine the depth of a patient's medical crisis?
So in terms of markers, as medicine has gotten more technologically advanced, and I always remind this of the medical students and the residents, first of all, we should never get away from laying hands on the patient, meaning a careful physical diagnosis, trying to bond to the patient. First of all, that's important for letting the patient know that you care about them. But also, you can get tremendous diagnostic clues about whether a patient is getting better or worse by doing careful physical examination. Second of all, blood tests. We've gotten so sophisticated in terms of our serum or blood markers, we can see trends developing in the intensive care unit. For example, if a patient's blood count is going down every single day they're in the ICU, it's very likely they're internally bleeding, even if we're not seeing it. Similar with heart attacks, we have markers we can look for. Now, Other aspects that we look for are the amount of support the patient is needing. So usually when a patient comes to the ICU, they're in shock or they have organ failure. They're going to need many of their organ systems supported. In fact, they may need the ventilator with the breathing tube. They may need what's known as vasopressors, which increase the patient's blood pressure to provide adequate blood flow and oxygen to their brain, to their heart, to their kidney. So if we see a downward trend in those requirements, that they need less oxygen, less ventilator, less vasopressor, that's reassuring. But also I want to mention, often when you have 2 or more organ failures, there may be plateaus. So patients may get better for a couple days, then flatten out, then get better again, or you can come down. So simply the fact that a patient may level off on the vent or vasopressor doesn't mean that they're not going to get better. You have to chronologically and serially follow them moving forward, and then incorporate all that data together to form an appropriate assessment of the patient.
Which markers require patient studies and consultation before a path forward can be seen?
So certainly, starting, 2 of the most important organs are the heart and the lung. So when we look at the heart, we're looking at the patient's primary heart function, how well the heart's beating, and we have monitors that can assess that. Also, as I mentioned earlier, the amount of support they need. There are medications that help squeeze the heart. That's called inotropes. There are other medications.
Is that word?
Oh, inotropes, INOTROPES. And there are other medications that support the blood pressure by squeezing the blood vessels down and increasing blood pressure. So that would be an important marker. In terms of the ventilator, how much oxygen is the patient on? How does the arterial blood gases look, which are measurements of the patient's blood, looking at the blood chemistry? Can we reduce the amount of support? And then other organs that are important, the kidney, are they making urine? Do they need dialysis? Is their liver functioning? Because every medication we give them has to go through the liver to be metabolized and put out of the body. So those are all major markers that we look for.
Thank you. How meticulous do you consider yourself in terms of study or consultation before you begin making decisions?
So I would say I'm very meticulous. I take my responsibility as a physician in the intensive care unit or in the operating room extremely seriously, that I don't want to make medical decisions or make consultations without accumulating a large body of information and scientific data, because in reality, when you're dealing with critically ill patients, the more information the doctor and the team has, the better the decision you're going to make, and also the better advice you can give to the patient or the family about what their prognosis is. If I see a patient, and I've done critical care for 30 years, but if I see them for 10 or 15 minutes, I can't really give them an accurate assessment about their prognosis. I have to spend the time with them. Usually an initial consultation is about 90 minutes, and then the more days and more visits I have with them, the better I can prognosticate what the patient's outcome will be.
Thank you. I don't want to skip into your reports yet, but you use a term in your reports called a patient declaring themselves. What does that mean to you?
So it's a term of art within critical medicine, a patient declaring themselves, meaning that often the patient is the best indicator of their prognosis. You simply have to give the patient enough time to let that patient, man or woman, young or old, show whether their organs can rebound from the injuries and whether they can heal themselves with the help of the doctors, the nurses, the medicines. So often when we have a critically ill patient, particularly if there's something sudden or dramatic, they've had a massive stroke, a massive heart attack, the best way to give the patient, the family, accurate information is to watch them for 72 to 96 hours, 3 to 4 days, and watch how they do through that critical phase. If their organs level off and plateau or even get better, that's going to be a more favorable prognosis. If, on the other hand, they don't do that, then I can, with reasonable assuredness, talk to the family about possibly proceeding through palliative care and withdrawal of support.
Why 72 or 96 hours if the person has suffered an insult like a stroke or a heart attack?
So when patients have major organ dysfunction, particularly the two examples that were mentioned, stroke or heart attack, the body often goes through a process of swelling. Much like if we hurt another part of our body, that you get inflammation and swelling. So it can be very difficult, particularly with the brain, for a doctor to prognosticate whether or not a patient will wake up unless you let the swelling in the brain go away. So usually you need 96 hours to have the amount of edema in the brain reduced to the point where I can really then make an accurate assessment whether the patient will regain consciousness, whether the brain imaging, either by CAT scan or MRI, is truly accurate, and whether there's going to be more bleeding or more problems that we might either have to surgically address or there may be no treatment for. But to rush to a hasty judgment, particularly about brain, heart, and kidney function, can often fool you, because I've had patients who appear to be deep in coma, and then after 96 hours or 5 or 6 days, they slowly wake up and become fully conscious again. So you really need to give that patient enough time to allow their own body to tell the doctors and nurses whether they're recoverable.
Does some metabolic blood work or other lab markers need time to develop also?
Yes. So one of the common diagnoses that critical care doctors give patients in the ICU is known as metabolic toxic encephalopathy. And what that means is that encephalopathy means the brain doesn't work. And toxic metabolic means that there are basically waste products or byproducts in the blood that are basically making the brain not function properly. So we, first of all, need to make measurements in the blood, look at blood chemistries, also look at arterial and venous blood gases to make sure where the patient started and whether or not those are improving before we can say that the brain dysfunction is not related to toxic metabolic encephalopathy. So a classic example is serum lactate. When the body has low blood pressure or low perfusion, the muscle and the gut will often make this toxic compound called lactate. And when that builds up in the body, in you or I, the liver would metabolize it and get rid of it. But if you're in shock, the liver is not functioning normally. So you build up higher and higher amounts of lactate. If that's in the blood, you can't reliably talk about the brain not working. You first have to try to get rid of the lactate to totally say that the brain chemistry is or is not going to be able to recover.
What about appearing to be obtunded or having pupils fixed and dilated? Does that mean that that person is not someone who should receive this ICU trial?
No, not at all. So certainly, if a patient has fixed and dilated pupils, I will admit that's an ominous finding. That's not something we would like to see. But first of all, you have to always understand that in the early phases of resuscitation, shock affects the brain. You may have decreased blood flow, decreased oxygen in the brain. So you could have a patient that initially appears to be either dead or trending towards death, but once they're fully resuscitated, certainly may surprise you as the doctor. So again, it goes back to that process of declaring themselves. You want to first make sure that you've exhausted all avenues of the workup and the diagnosis before concluding simply that the patient's brain or that their neurological status is not salvageable.
What type of ICU did Mount Carmel appear to have from 2013 to 2018?
So Mount Carmel West had what's referred to as an open medical surgical ICU. There are some ICUs in the United States that are what are called closed ICUs. If you get admitted to the ICU, you basically hand over all care to the ICU team. In our institution, the burn ICU is that way. You can't get into the burn ICU unless you're admitted to the burn team. But there are other ICUs in which it's called open, meaning that various consultants, various medical doctors, surgical doctors, even the ICU team are working collaboratively on the patient. And the ICU doctor, rather than being the sole director of the ICU, is really working as a consultant to the admitting doctors. And in reviewing the charts from Mount Carmel West, it appeared that the admitting doctors would consult the critical care team, and they would then provide liaison or consultative services for the patient.
Okay. Why does that matter in this case?
Well, it has tremendous importance because, again, when you're a consultant, the ultimate responsibility for the patient is the admitting physician, the physician who is bringing the patient into the hospital and assuming primary responsibility both for doing what's known as the history and physical, but also the discharge summary. So when you're a consultant, you should always relay your recommendations, both in the electronic medical record, but also verbally, to the primary team. That's particularly important if it's decisions that would impact the life or death of the patient. You wouldn't want to unilaterally, as the consultant, progress to make life or death decisions without including the admitting physician, who may well know the patient much better than the consultant who's just been brought on the case that day or in the last couple of days.
Thank you. Doctor, we've heard during the trial about a lot of treatments and medical terms. I'd like to ask you about a few, just to touch upon them. We certainly know about intubation. That's been the subject matter of the last 5 weeks. But I'd like you to talk a little bit about what the intubation means for the patient, other than just providing a breath of life.
Yes.
What other functions are being provided?
So one of the first lessons that you're taught in anesthesia or in critical care are the ABCs: airway, breathing, circulation. If you can get those right, then 90% of your job is done correctly and the patient will do well. So obviously in many critically ill patients, and particularly those who are going to get medication that can alter their sensorium, their airway could be in jeopardy, meaning that they may not be able to maintain a patent airway, and they may have to have an artificial breathing tube placed in. This serves essentially as a connector or tunnel to a ventilator, which can then not only provide oxygen to the patient, but also help blow oxygen mixtures into the lung and facilitate the removal of carbon dioxide. Because the human lungs, in you or I, really has two major purposes: bring oxygen in, but also to get carbon dioxide out. So having the breathing tube will assure of that. Also, patients who are sick, they can't clear their secretions well. They make a lot of mucus. They may have some infection in the lung, which can also add to the mucus. And they may even sometimes have extra fluid, pulmonary edema, or even blood. So by having the tube in, it allows the doctors, the nurses, even the respiratory therapists to suction the airway and clear all that phlegm, mucus out of the body. It also allows critical care doctors to go down the breathing tube with a light wand and look into the lung. So if we can see deposits of pus, we can clear that out. And then we also have various devices we can attach to the breathing tube that are gas monitors. And they not only talk about the function of the lung, but they give us an assessment of how well the heart's pumping. And that's called capnography, which is really just a term of art that describes the measurement of carbon dioxide coming out. But of course, if your heart's not pumping well, you're not going to remove carbon dioxide from the body. And then lastly, it also allows doctors, nurses, and respiratory therapists to deliver medications. For example, patients who have asthma or emphysema may need medication to open their lungs up, what we call bronchodilators, and those are always best administered through the breathing tube.
Why is it important to get rid of CO2?
So the human body is really delicately balanced in terms of the delivery of nutrients into it, but equally important, the removal of waste products. So the major two waste products in the body, one goes out real quickly, one goes out slower. The quicker one is carbon dioxide. When we engage in metabolism, whether it's in the cell of my finger or in the brain, that cell makes carbon dioxide, and the body has to get rid of it because it's basically a poison. It makes the body acidic. And the only way out is really to blow it out through the lung. The acid that floats in our blood has to go out through the kidney. And again, that will take hours or days. So if you have problems with carbon dioxide excretion, the body will quickly become more acidotic, and that not only impacts the lung, but it affects the function of the brain, it affects the function of the heart and the other organs. So you really, from the time we come on this earth to the time we depart, the body tries to keep the amount of CO2 in the blood relatively in a narrow window or band so that the blood chemistries function properly.
Thank you. Let's talk about shock or liver shock. Are those the same thing, or I guess shock liver? Are those related? Are they the same thing? What are they?
Yes, they're related. So the way to look at it, the bigger umbrella is shock, because shock is any time that the delivery of blood, oxygen, and nutrients to various parts of the body doesn't match the needs of the patient. So for example, cardiac shock is the heart has a heart attack, it's not pumping well, it's not pumping blood, oxygen, nutrients to the rest of the body. Now, one of the organs that is among the most important in the human body is the liver. First of all, it gets a lot of the blood flow from the heart. Anywhere from 15 to 25% of each pump will go through the liver. And the reason is because, first of all, the liver absorbs all the nutrients and helps in metabolizing proteins and other substances that the body needs to make. But then the flip side of the liver is it's where a lot of the breakdown occurs. So that lactate I mentioned before, it must be metabolized in the liver. Any medication we take, whether it's Tylenol or an antibiotic, primarily has to be taken to the liver where it goes through a series of metabolic processes. In essence, think of the liver as a factory, or really, some place where things are made or are unmade. So if you go through shock and there is inadequate blood flow and inadequate oxygen to the liver, and the liver shuts down, that often then can put the rest of the body in a state where it's temporarily not working well. And again, much like I mentioned earlier, you have to give the liver at least 3 to 4 days to see whether or not it will rebound, because the human liver is amazing. You can lose 90 to 95% of the functional capability or capacity of the liver, and with support you can bounce back and regain most of that back. But again, you have to give the liver enough time to recover. It won't happen instantaneously.
Thank you. Talk to us about vasopressors. What are they and how do they work?
So vasopressors are a category of medication that doctors use and order for nurses to administer to patients that primarily support a patient's blood pressure. So going back to what I said before about shock and how shock interferes with the delivery of oxygen and nutrients and blood to the body, one of the classic hallmarks of shock is that patients have very low blood flow and very low blood pressure, which we measure. That can be measured on the arm, or it can be measured by putting a catheter inside the artery itself. So vasopressors are either medications that our body itself makes, and then we basically give them pharmacologically, or medications that are similar in effect that help doctors and nurses support cardiovascular function through the phase of shock. And again, we use them even in surgery. If I'm delivering anesthesia for a heart surgery patient, they're going to get vasopressors both during and immediately after the surgery until their heart recovers, then we can wean them off. So one can't conclude simply that if a patient's on vasopressors that they're going to die, because again, most cardiac surgery patients live. They just have to overcome the initial phase of the stunning of the heart while it's being operated on, and then we can wean them down. But vasopressors are there to support blood pressure, support cardiac function, to provide adequate blood pressure and blood flow to the other organs.
Are there patients where they need multiple vasopressors?
Yes, because the human body itself has various pathways to support blood pressure. We similarly mimic that in the intensive care unit by having various vasopressors that can be used to support the patient. And it's interesting, certain patients will respond better to one than the other, so we may have to switch in midstream when we provide the care. Also, some patients may require 2 or 3 vasopressors, particularly if there is a lot of acid in their body, because vasopressors work indirectly. The way to think about vasopressors simplistically is that they're like the key to your front door. Without the lock, they're worthless. So the vasopressor is injected in the blood, usually on an infusion. We'll then look for the receptor, which is the lock, and then we'll engage there to create the reaction. Acid can alter the function of the lock. So if a patient is very acidic, you may have to first address the acidosis before the vasopressor will work. And that's why many times in shock, you'll see a patient on multiple vasopressors, supporting them enough so that you can get dialysis, you can get the ventilator, all those things to reverse the acidosis.
And are those medications that would be used to support this 72 to 96-hour ICU trial?
Correct. Usually, vasopressors are run to support during that period of the patient revealing their ultimate ability to recover from the disease. They will require 1 or more of those vasopressors during the period of time while they're getting maximal resuscitation.
Let's talk about pH values. Why does the pH in a person's body matter?
So, again, the human body has been really created and designed with really exquisite architecture. Most of the body's functions require a relatively narrow band of pH to function well. This includes cell membranes, enzymes, proteins that are in the body and in the tissue. So from the time we're born, we usually have a pH just slightly above that of water, so we're just a little more alkaline. So our pH in the blood is usually between 7.35 and 7.45. As we get sicker, we tend to get more acid in the blood, so we become more acidotic. And as I mentioned, it becomes kind of the cat chasing its tail. If you get more acid, the organs are going to function less well, which could make more acid, which could make the organs not function well. So usually you need a period of time of stability, both on the ventilator to blow off carbon dioxide, and perhaps even putting a patient on dialysis or giving them a buffer in their blood to neutralize acid in the blood before you can say that they're not going to recover and that the vasopressors no longer have utility. So again, it usually works hand in hand. We're addressing the pH and the acid-base balance while we're trying to support them with the vasopressors. And then finally, many times, once you normalize their pH, you can then start coming down on the vasopressors.
What kind of a window do you have to correct an individual's pH?
We usually would like to do it within the first 8 to 12 hours, but it may or may not be feasible if the patient has persistent kidney or liver dysfunction, because as I mentioned, the liver and the kidney both work together to help normalize the pH of the blood. So it can be that it might take longer than 12 hours to get that accomplished. So again, we want to try to do it slowly and methodically to achieve the best outcome, not have rapid swings in the patient's pH up or down.
And when does a pH out of the proper range become life-threatening?
So certainly we become exquisitely worried when the pH is less than 7.10. So again, normal is around 7.40. When it falls downward, that actually means there's more acid in the blood. So that's a little bit confusing. Low pH means high acid. So below 7.1, you start to see the organs not working as well. When the pH falls below 6.90, that usually is a very ominous finding. But again, you have to be very cautious because many type 1 diabetics will present with very low pHs, less than 6.9, and if you give them insulin, you bring their sugar down, you give them fluid, they'll fully recover. So not every patient with a severe acidosis is potentially fatal. It really depends on why they develop such a severe acidosis.
Thank you. Talk about lactic acid, and is that related to pH?
Yes, so lactic acid is most definitely related to pH. The body usually uses oxygen as fuel. Much like we put, for most automobiles, we put gas in the gas tank, assuming it's not an electric car. That's the fuel of the engine. The fuel for the body is oxygen. The reason we need oxygen is so that it can metabolize sugars in the cells. Now, if there's a lack of oxygen, the body does have a backup system. It's called anaerobic, meaning without oxygen, metabolism. It can only do this for a short period of time, and in doing that backup system, the body is forced to make lactate. This is why marathoners start to make lactate as they run further and further into the marathon, because usually beyond 18, 19 miles, you don't have enough oxygen in your muscle, you make lactate. The same is true in critically ill patients. If they have a deficiency in oxygen and they go through this abnormal metabolism, you'll start to see higher levels of lactate, which usually are correlated with a lower pH or acidosis. So that's why frequently we'll use the term a lactic acidosis, meaning the cause of the acidosis is the production of lactate.
What does that mean for the patient's comfort level?
Well, in most cases, it means nothing, because unlike the marathoner who makes lactate in the muscles and may have sore muscles, in the critically ill patient, that's not what's happening. They're having a cellular imbalance in oxygen, so you have lactate in the blood. They're not feeling pain from it, and usually the buildup of the lactate is the clog in the system is the liver. The liver is in shock, so it's not able to metabolize the lactate, so it's building up in the blood. But in my experience of now 29 years in the ICU, patients with elevated serum lactates do not experience pain from that.
Can lactate accumulate from surgeries?
Yes, you can have lactate develop. For example, certain surgeries have to be done with a large, heavy tourniquet on the extremity to avoid bleeding. Many times, extensive surgery of the lower extremity, the leg, is done with a big tourniquet. During that surgery, which may be an hour and a half or 2 hours, there may be little or no blood flow other than what gets through the bone to the patient. So you may have high amounts of lactate in that limb, so when you drop the tourniquet, lactate washes out to the rest of the body to be distributed and then ultimately metabolized. Also, if the surgery results in low blood pressure, or if there's hemorrhage and shock, the body will make lactate. So very commonly, a trauma, gunshot wound, a knife wound, you'll see higher levels of lactate because of the loss of blood during the surgery.
Thank you. Is there, let's turn our attention now to cardiopulmonary resuscitation. Could you give us a definition of what CPR is?
Certainly. So when the human heart is functioning normally, it has two components. One is the electrical message that it sends itself. So we're born with an inherent pacemaker towards the top of the heart that tells the heart, you need to beat. And it'll then send it through the wiring that's inside the heart to the muscle, and you'll then get mechanical contraction. So that's the squeeze or pumping of the heart, which sends blood through the rest of the body, and then when the heart releases, it pulls the blood that has no longer has any oxygen back into the right side of the heart to start the process all over again. So CPR first came about in the late 1950s and early 1960s when it was realized that if a patient's heart stops, whether it's electrical or mechanical, so whether it's because they have an arrhythmia or they have a heart attack, that we can externally compress the chest. So if we press on the breastbone, which is directly over the heart, and we pump down vigorously, we can squeeze the heart between the breastbone and the vertebral column, the spine, which essentially pinches the heart and will send the blood that's in it showering to the rest of the body, much like if the heart's pumping itself. Also, when we allow the breastbone to recoil, when the chest goes back up, it creates a vacuum inside the heart that will pull more blood in it. So if you combine high-quality CPR, which is the chest compression, often with artificial ventilation, either mouth-to-mouth or in today's era with COVID and other disease, usually it's with a bag where we're squeezing over the mouth to blow oxygen in, you can generate a percentage of the normal cardiac output. It's never totally normal, it's reduced, but enough to sustain life. And scientific studies have shown, whether CPR is done in the hospital or on the streets of Columbus, that you can usually get 1 in 5, 1 in 4 patients resuscitated, higher if you have electrical defibrillation that can then allow that patient who might well be salvageable to be transported by EMS to a hospital. And then finally, that what I just described is called basic life support, or BLS, basic life support. We can combine it with advanced cardiac life support, which is usually done by paramedics or doctors, where we add the breathing tube, we add injecting medications to start the heart, the electrical defibrillation. So there's basic and advanced cardiac life support.
Thank you.
Hold on for a second. Ms. Crabb, how you guys holding up? It's getting close to break time. You're good? Okay. Keep going.
Thanks. Are there studies about survivability between people that have an arrest outside the hospital versus inside the hospital?
There are, yes. There have been a host of scientific studies, both in the United States, Europe, and Asia, looking at survivability. And what we've discovered through rigorous scientific method is that early bystander CPR, meaning that if someone would fall down in front of me and have a heart attack, if I start CPR early, that increases their chance of surviving, not only to get to the hospital, but to then successfully be discharged. Early defibrillation, getting one of those AEDs at the airport, putting it on the chest, and then it tells you when you need to shock the patient, that will help them survive. So what we have known now by looking at data from all around the United States and Canada, that if you have an out-of-hospital arrest and you get high-quality CPR, early activation of 911, that, again, roughly 20 to 25% of those patients will survive to the hospital and will be able to enter the hospital for potentially cardiac catheterization, possible cardiac surgery, and what have you. Obviously, if you have an event in the hospital, depending on, again, why you needed CPR, the evidence is that it's usually a better outcome. Why? Because someone like me, an intensivist or an ER doc, is right there. We're immediately intervening. We're immediately giving the drugs. some of these patients are already on the breathing machine, so usually survivability is somewhat better. And then, of course, we have to factor in age plays a role. You're more likely to survive CPR if you're age 40 than if you're age 80, just because as we all age, we do have slightly less capacity for insults to the vital organs.
Does capnography, which you previously discussed, have a relationship to CPR or the effectiveness of CPR?
Yes, absolutely. So what we've realized over the last 30 years is that capnography, measuring the patient who's getting CPR's ability to produce carbon dioxide, is one of the most accurate and least invasive techniques of monitoring the efficiency of the CPR. By that I mean we're not having to stick them with a needle, because you're not going to be able to do that out in the field. You're not going to be able to put a catheter. That's got to happen inside the hospital. But EMS and paramedics have portable capnography that they can put on the end of the breathing tube. So if CPR is effective, capnography is going to show usually a CO2 above 20. So if I were to put a capnography on myself or one of the members in the court, capnography usually ranges between 35 and 45. With CPR, if you get above 20, you're getting good blood flow to the heart, the brain, and the organs. As you go lower, if you start seeing capnography below 5, either the person isn't doing CPR well or there's something else going on. You have to investigate, because those low numbers usually don't prognosticate a good outcome.
Thank you. With CPR, is it possible to fracture a rib?
Absolutely. Remember, I mentioned that CPR must be done vigorously to achieve high-quality chest compressions. I mean, if you were just doing baby CPR on an adult, it's really going to be ineffective, because you have to compress the breastbone usually 1.5 to 2 inches down into the chest and let it recoil. So obviously, if you have an older patient, one that may have osteoporosis of their ribs, you could either fracture one or more ribs, or sometimes you'll temporarily separate the breastbone from the cartilage that attaches it to the ribs. Again, that's usually not a fatal event. I mean, as long as you get their heart back and you get blood flow to the brain, we'll accept a few broken ribs. That should heal if the patient survives. We can address that later on. But the key thing is to have high-quality CPR. But yes, we do look for that. The one factor we would certainly want to make sure is if a broken rib were pointed inwards and it punctured a lung, we would have to act immediately, because we'd have to reinflate the lung. Otherwise, the lung would stay deflated.
Thank you. Are there commonly patients in an ICU that have had CPR?
Oh, yes. If, for example, you were to look at an adult ICU, clearly, probably, again, and it varies on any given day, but 8 to 10% of the patients in an adult ICU would have had CPR at some point. Higher in the cardiac unit, probably, less in the medical ICU, but there are a lot of the patients that have had either some short-term CPR or some electrical defibrillation for arrhythmias that is part of the advanced cardiac life support needing resuscitation. So again, simply needing CPR doesn't mean a patient's going to die. Many of those patients will eventually walk out of the hospital.
Jumping ahead a little bit, if you had a patient that you were going to perform a compassionate extubation on, and that person had had CPR, what would you be looking at as far as that CPR to put that as an element into deciding drug dosing?
So in patients who have had one or more rib fractures, and have been on life support. Obviously, one of the aspects that I'm assessing in my physical exam is the patient grimacing? Do they show signs when I take my stethoscope and put it over their rib cage or the heart? Are they indicating to me that they're having pain with just light tactile touch? That would mean usually I would need to give them more, because you'll have some patients who don't have a lot of pain. Also, we're looking for paradoxical breathing motion. If the ventilator blows their lungs up, like if I'm puffing in a balloon and you get the balloon up, but part of their ribs goes in, so it's moving in the opposite direction of the lung, those patients are more likely to have pain. That's called the flail, F-L-A-I-L, chest syndrome. If you have ribs, the same or more ribs fractured at two different spots, you can get that abnormal motion. So the other things we look for, has the patient been tearing up? You know, are they showing signs, even if they can't speak, tears in the eye, hand grips? If they've been turned by the nurses, that's a hallmark of when you can elicit pain from the ribs, because the nurses will turn the patient every 2 hours. So if the nurses are communicating to me or the team, oh, every time we turn them, their heart rate goes up, their blood pressure goes up, their face is grimacing, I'll know pretty quickly that the ribs are causing pain. In contrast, if I'm not getting that feedback either on my physical exam, an assessment of the patient, or from the nurses, then likely the ribs aren't a major problem causing the patient discomfort.
Thank you. What is organ failure?
So organ failure is a generic term used by doctors in the ICU, nurses, and other healthcare workers to diagnose when a patient's major organ or organs are not functioning normally. So for example, in COVID, if the lungs shut down, that would be respiratory organ failure. The lungs, the respiratory tract, are no longer working and need a ventilator. If the kidneys totally shut down and are not making urine, are not putting out the organ toxins that are produced through the kidney, that would be renal or kidney failure. They would need dialysis. So organ failure, whether it's one or multiple organs, is a medical diagnosis when the organ no longer can function appropriately, its physiologic role in the body.
Can people recover from multi-organ failure?
Yes, so certainly patients are more likely to recover from 1 or 2 organ failures than if they had 10, right? Because obviously the more organs that have failed, the sicker the patient they are. But this again goes back to that period of time that you have to be careful. A patient having a transient, which means temporary organ failure, doesn't necessarily mean that an organ will not kick back in. The classic example, again, going back to the kidney, I routinely have patients that have acute kidney failure that make no urine for 18 to 21 days, so 2.5 to 3 weeks, that in the 4th week will start making urine and their kidney function will come back. That's not uncommon. The same thing with liver shock or liver organ failure. We have patients who we have to support for 1, 2, 3 weeks whose liver will come back. So you have to be very careful of a physician to just unilaterally conclude that the organ will never come back. And you have to really, again, look at the blood chemistry, the serum markers that we test in the laboratory, other diagnostic tests within the body, such as imaging, ultrasound, to look at blood flow. If I have a patient who has no blood flow to the liver with ultrasound, well, then more likely than not, it's never going to come back. But if I still have blood flow through the portal vein to the liver, then I'm going to be hopeful that they may get return of function.
What is brain death?
Brain death is a very specific medical diagnosis that critical care doctors, neurologists, emergency room physicians, neurosurgeons will make. It basically means that not only have all the cognitive functions of the human brain, so emotions, thoughts, speech, been lost, but also that kind of the autonomic functions, those in the brainstem that you and I don't need to think about, are also lost. So the brainstem are those parts of the evolutionary brain that go back to reptiles. They tell the heart to beat, they tell the lung to breathe, they tell the stomach to digest food, all the things that we don't have to think about when we're in our sleep. Nobody's thinking about breathing or thinking about the heart functioning. So in order to declare somebody brain dead, we have to go through a methodical assessment, both to assess brainstem function, higher cognitive function, and then, if need be, look at blood flow. Because remember I mentioned with the liver, if the liver has no blood flow, you can safely say it's dead. The same with the brain. If we have a patient that we're not clear about whether or not they're brain dead, then we send them for a nuclear imaging study to look for blood flow to the head. And if there's no blood flow, then we can safely say the patient is definitively brain dead.
What's the difference between brain death and an anoxic brain injury?
There's a very big difference between those two diagnoses. So first of all, let me define the word anoxia, because that's not a common term if you're not in the hospital. Anoxia means the total lack of oxygen. So anytime you hear the word anoxia linked with any other organ, brain, liver, kidney, it means that there was a period in which no oxygen went to that organ. So most commonly, doctors and nurses and healthcare workers use it regarding the brain. So anoxic encephalopathy means that the brain is not working normally because there was either a brief or prolonged period of lack of oxygen. Again, I would compare this to what I mentioned earlier this afternoon. Toxic metabolic encephalopathy has nothing to do with lack of oxygen. That's poisons in the blood that are interfering with brain function, whereas anoxic encephalopathy mean that the brain is not working normally. Now, again, patients may have a period of anoxia, low or no blood flow with oxygen to the brain, but still have some recovery. This is one of those areas that I mentioned in the introduction about things that we've discovered. We have, over the last 10 years, discovered if we aggressively cool a patient down, so rather than be 98.6 degrees Fahrenheit, we make them 60 degrees Fahrenheit by putting cold blankets over them, sometimes packing the head in ice, putting catheters in the groin that will cool their blood. You reduce the amount of oxygen the brain needs, and you can often help the brain recover during these periods of low oxygen. And that's called targeted hypothermic temperature management, and it's a technique that has been devised in the United States to help with brain injury. So again, the fact you have anoxia doesn't mean you're brain dead. You could have anoxia leading to brain death, yes. I mean, certainly if a patient went 30, 60, 90 minutes without oxygen to the brain, more likely than not, you're going to be brain dead, unless you fell into a lake and were basically frozen at the outset. But so you have to be very careful to parse those off. Brain death has a very specific diagnostic criteria, of which you need to do an apnea test and a brain death exam, and then possibly a blood flow study, whereas anoxic encephalopathy simply is explaining what the root cause was for the brain not working properly.
Let's talk about the hypothermia. Is that is that a technique that would be employed during that 72 to 96 hour period of ICU trial?
Correct. So what we and other doctors throughout the United States have learned is that the sooner you can cool a patient who's had cardiac arrest, particularly if it's an out-of-hospital ventricular fibrillation, the more likely it is that the patient will recover some or most of their brain function. It reduces the amount of oxygen the brain needs to function, but also it reduces the amount of swelling in the brain after you've resuscitated the patient. So usually what critical care doctors have done for the last 10, 12 years is as soon as we either get called to the emergency room or see the patient, we'll start targeted temperature management as soon as possible and then try to achieve low blood temperature, really cooling the patient within the first 6 hours. Again, clearly it's not like a light switch. You don't just immediately cool them. It's a process, but you want to get to the targeted temperature within 6 hours and then try to maintain that for 24 hours. And then after that, we slowly bring them out of that state of hibernation. So then over the next 24 hours, we kind of back them up. So this would occur during that period of 72 to 96 hours in which we're allowing the patient to declare themselves whether the brain and organs will again function. We would be doing targeted temperature management on patients who are suitable for the protocol.
And when was,
Ms.
when,
Robb, hold on. It's time for a break, ladies and gentlemen. We're going to give you 15 minutes. Remember the admonition. Mr. Peckus, call us up.
All rise.
Have a wonderful break, guys. Have a seat, Doc. Ms. Grubb, anything for the record?
Not right now, Your Honor.
Y'all can be seated. Ms. Menashe?
No, you're
Okay. We're on break for 15.